Welcome, everybody. It's a pleasure to be here with you today, where I have the opportunity to share a little bit more with you some of the research work that we have been doing over the past couple of years and that we're planning on doing for the next couple of years as well. So as a place to start, I wanted to share a bit about what is our team's mission. And our focus is to prevent parasitic and enteric diseases with a focus of norovirus and rotavirus in vulnerable populations of the Americas. We're also aim to mentor the next generation of public health professionals. So as I was thinking about this talk specifically, I was thinking right now there's so much swirl and we're in a really strange situation. And what would be most helpful to share during this talk? I can talk about research, which is what I will be doing, but then I should also touch a little bit about what's happening. And so I reflected back on what were moments of crises, emergencies, and what were some lessons learned from that. And so what I'd like to start out with is 2014 Emory norovirus outbreak response, which some of you may recall if you were around back then. And my role in that work to set the stage for some of the norovirus research, which I'll be sharing with you today, but also to talk a little bit about what I learned from this moment of crisis and emergency that I am currently applying right now. So we'll talk about the norovirus outbreak. We'll shift over to the research that I do, and then we'll circle back in terms of lessons learned from crises emergencies that I'm applying right now. So again, for those of you who may recall, this was fall semester, Thursday, November 12th, 2014. And in the wee hours of the morning, the first Emory Emergency Medical Service patient alerted. This was in Royal Hall, a little south of Rollins School of Public Health. It was an 18-year-old female freshman student who experienced intense nausea, vomiting for about 2 hours, a lot of abdominal pain and weakness, and she was transported by ambulance to the Emory emergency room. And after every 30 minutes, every hour or so, the calls continued throughout the morning, throughout the afternoon as well of the following day. And around the university, Dr. Michael Huey, who was then director of student services, sent around an Emory-wide email. As of this evening, 74 students have been seen and treated at Student Health Services and the Emory University Hospital Emergency Department. Stool cultures from several ill students have been sent to the State of Georgia laboratory and results are pending. At the time, we had been working with Dr. Marshall Lyon, who was a physician working with the Emory Ebola patients a few months back. And we had been working with Dr. Marshall Lyon on several of our human norovirus human challenge studies, which I will be sharing with you in just a bit. And he contacted Christine via text, and he reported a large number of students seen at the emergency room with severe vomiting. And he asked if we were interested in receiving samples. At the time, Marshall just asked us if we wanted samples since he knew we were doing a lot of norovirus work. And so that was a message that Christine received. So of course, this happened late in the evening. All of us were tired, ready to go home and all of this. And so I wanted to stop my screen share and share a little bit more personally what happened that evening and the conversation that Christine, Mo, and I had at the time. So what happened was Christine walked over to my office. I was getting ready to go home. And she said, Juan, we just heard from Marshall, and Marshall told us about the situation. And this sounds like a norovirus outbreak. I've helped with a lot of norovirus outbreaks in my experience in my career. They're not fun. They're exhausting. I don't have the bandwidth right now to engage in this work if it does turn out being a norovirus outbreak. But if you are willing, then I'm happy to support you. I know you have a very vibrant and established laboratory team. So please decide what you want so we can inform Marshall as to next steps. So I told Christine, let me think about it. So Christine walked back to her office. I started to pace back and forth in my office and thought, what should I do? This is my community. If Christine and I are the norovirus experts, if it turns out to be norovirus, I have to say yes, because this is my home. These are the people I care about. And so I will say yes. So then after that decision, then I thought, okay, then what comes next? So then I thought, well, I need to sacrifice myself to save Emory. Unconsciously, this is what I was thinking. I will drop everything and save Emory. And so, of course, you can start to think, oh my gosh, this is a mindset that's not gonna end well. Number two, I had projects in Mexico and in Bolivia, Mexico on food safety, Bolivia on rotavirus vaccine response. And I thought, these still need to continue, and my teaching needs to continue. So if I plan everything well, I can get everything done. I can do the outbreak, I can do the Mexico work, I can do the Bolivia work, I can do my teaching. Everything will be fine. And so I drove back home. I told my husband, Scott, I'm so sorry. The next couple of weeks, you're not going to see me. I need to respond to this norovirus outbreak. So then I went back to Christine and said, yes, if it turns out to be a norovirus outbreak, I'm all in. I'll be glad to lead the efforts and to support, and I would welcome your help as we do. So let me go back to sharing my screen. And so these were the two mindsets that I had as I began the norovirus outbreak. The draining mindsets were like other people's needs, such as sick Emory people, are always more important than my needs. And number two, I can get everything done if I just organize and plan well. The mindset that did help me, however, is I will protect my team's personal needs from other people's needs, and I'm an excellent planner and an organizer. So with that in mind, the next day, I went back to Emory, and with my team, we asked Emory so that we could test the stool for the outbreak agent. However, all the stool had been sent to the state health department. So instead, myself and Dr. Paulina Rebolledo and an MD-PhD student seen here in the picture, Kira Newman, went to the emergency department to ask for a student-patient stool. Paulina, who's also a joint global health faculty member, had been trained in the BioFire machine that had been used for the Ebola patients about 3 months ago and could diagnose an agent from stool in about 2 hours. So we were able to convince some of our sick Emory staff and students to give us 2 stool samples. We went to the micro lab and we tested it by BioFire. At 4:15 that day, the first stool came back positive for norovirus, and then we loaded the second stool sample in the BioFire machine. So since, for those of you who don't know, norovirus is a big foodborne threat to consumer health and is the leading cause of foodborne illness in the United States, with about 5 million cases per year and also globally. And about more than half of produce-associated outbreaks are caused by norovirus, not only in the United States, but also around the world. It has a very low infectious dose, which we'll get into some of our data. High viral load. You shed billions of norovirus in 1 gram of feces. You shed it for a very long time, even after symptoms are resolved. It's hard to inactivate, lasts a long time in the environment, and for better or for worse, right now it's only human-to-human transmission. There are strains of norovirus that can infect animals, but they only cause illness in animals, and for human outbreaks, it's only human-to-human transmission. So you may have seen this in the news, and if you take a cruise ship, you'll probably hear a lot about norovirus. So coming back to that day on Friday, November 13th, our first stool came back positive for norovirus, and we were ready to load the second stool to figure out what we would do next. And so at that point, we were asking ourselves, what do we do now? Do we just tell everybody with just this one data point? Or do we wait 2 more hours until we are sure? But in these 2 hours, more people are going to be sick. And so how do we weigh these two decisions? And that's kind of the first decision that I wanted to share with you, the concept of time in an emergency, in a crisis. The myth is that everything can and must be done at once urgently. But the truth is that actually you have access to infinite decisions at every single moment of time. And with those infinite decisions at your disposal, you can decide what to do among those. However, you can only do one of those things at one time. You can't do everything. You have to pick one thing and do it. So it was important for me to start strengthening my one decision muscle and to also realize that I have to finish what I started. Once I decide to do that one thing, I need to finish it and then move on to the next thing. So what we did is we decided to do that one thing, which is to wait those 2 more hours until we were sure that it was norovirus. And so we chose that decision and moved ahead with it without telling other people around us. And so at 6:20, the second stool came back positive for norovirus. And at that time, we were then ready to share the news more publicly. So Paulina called Marshall to coordinate the Emory healthcare response, and I called Michael Huey to coordinate the Emory response. Dr. Michael Huey asked if we could help with the norovirus outbreak source detection and control. And I had already told Christine yes, and I had told Marshall that if it was norovirus that we would support. So of course I told Dr. Michael Huey yes. So fast forward to what happened towards the end. We ended up seeing 190 patients combined in Student Health Services and Emory Emergency Room. It was an Emory University-wide response with a lot of different institutions involved, including the RSVH norovirus team, including the Emory Student Outbreak Response Team, SORT. We did a lot of environmental surface testing. Specifically, we tested the equipment of the Emory Emergency Medical Services, their ambulance, after they had done routine testing and cleaning, and 4 samples came back positive, which speaks to the persistence of norovirus on surfaces. So even though the ambulance had disinfected and wiped down their surfaces, we still were able to detect norovirus RNA on these surfaces despite their disinfection. So they upped their disinfection protocols in different ways so that then we were able to confirm that we got negatives on after their cleaning. We received 3 different food samples from the Dawes Marcus cafeteria. And because at the time there was an Emory staff member that was violently vomiting in the trash can nearby some of these food items, and we weren't quite sure if it was a food that started the outbreak or perhaps there was another source. 2 of those food items were negative for norovirus and 1 was inconclusive. And this will be important later on when we talk about detection of norovirus, because it is hard to extract norovirus from these food matrices. And once you extract them, there's a lot of inhibitors that limit detection via RT-PCR, for example. So the aftermath was that our last student was seen on December 6th. We had about 189 individual students. 1 person came to both ER and also Student Health Services. We had about 31 students treated by ambulance, and we likely estimate that there were about 250 total cases in the Emory community. So we never identified what was the main cause. There was a lot of cost to Emory, to our staff, to our faculty, to our students who became ill with norovirus. And this set in place several emergency protocols for other outbreaks that may occur in the future going forward. So from a research perspective, we, with Marshall, Michael Huey, and others, we ended up publishing a systematic review of other university outbreaks that had occurred in the United States. And actually, at the same time that Emory had its own outbreak, the University of Virginia also had an outbreak. And then about 2 weeks later, Georgia Tech had an outbreak with the same strain that Emory had. So I think there was an Emory angel that floated over to Georgia Tech and then began another outbreak there. So our team also went and supported the Georgia Tech students and staff with their own outbreak. So the question that I want to come back to at the end is, how do you live your best life while managing a public health emergency? What's your aftermath? What's your mindsets? What are your practices? What are your habits and rituals? And so I show you this picture of a wrecking ball, and I'll stop screen sharing again. And I show this picture because that's how I felt. I felt like I got smacked in the head with this wrecking ball. I was exhausted. I was tired. Fortunately, I was able to reconnect with my husband at Scott during this period. But it was hard to be energized again with the teaching and with the research and everything that happened. So at the end of this talk, we'll talk again about lessons learned from managing a public health emergency and crisis. And I invite you also to think about what are mindsets that support you and to help you as you navigate different crises in general. So let me go back and now transition to a little bit of the research work that we are doing. So I showed you this slide earlier, which is about norovirus. And so I wanted to start showing you some of the data that supports some of these claims about norovirus being a huge foodborne threat and also informs what I'll be sharing with you in terms of our research. So it has a low infectious dose. And to determine that, with Christine Mo, Peng Bo, myself, and others have contributed to several human challenge studies where we invite volunteers from the community to visit the Emory General, the GCRC, the Clinical Research Unit, to receive Norwalk virus inoculum that's been safety tested, IRB approved, etc. And during that stay, we collect multiple specimens, serum, saliva, stool, vomit, and their symptoms. Once we have confirmed that they have stopped being symptomatic, we then invite them for outpatient follow-up visits, and then we collect additional samples from them as well. So from some of the early studies that Christine had done, both while she was at UNC and also here at Emory, we estimated the dose that was necessary to become infected. So if you look at the middle column, these are the estimated genomic copies that were quantified. And the third column are the total number of subjects, and the last column is the percentage that were infected. So one thing you can see is that between 2 and 20 genomic copies are the amount of virus that is needed in order to infect our human subjects. So later on, Christine and Peng Bo published one of the seminal foundational pieces with Peter Tunis, who's also a visiting adjunct professor in global health, on the dose of norovirus necessary to infect an individual. And so they calculated that the ID50 was 18 viruses for Norwalk strain. Other strains have different ID50s. But this was one of the first indications that led the stage for future modeling work and future public health efforts to respond to norovirus as a public health threat with very, very low infectious dose. So then in terms of environmental stability, we then also did some work to quantify how long did norovirus last in water, groundwater, such as from a well, and could cause infection in humans. So for that, I wanted to ask you a question to think in your mind as I go through the data. How long do you think norovirus will last in water and still make people sick? Will it be 1 day? Will it be 1 week? Will it be 1 month? Or will it be much, much more? So take a moment to think about which would be your answer in terms of how long norovirus lasts in water and can still make people sick if they were to drink that water. So to answer that question, we again set up a human challenge study where we mixed Norwalk inoculum norovirus together with groundwater that was sampled from a well from one of our staff members, Stu Hooper. And then we stored that mix at room temperature in the dark for various days. We gave some of that to human volunteers, and then we took some of that and tested it to see if we could detect RNA. So let's go and answer the question. So in the first column will be the days that we incubated Norwalk virus before we gave it to human volunteers. And in the second column will be the number of volunteers that were infected divided by the total number of volunteers. And we quantified infection by whether their stool, their vomit, or their blood responded to norovirus. So our control was 0 days. We expected that both would become infected, and indeed both did become infected. Then at 7 days, 1 week, both volunteers also became infected. So these were new volunteers at every single time point. Then we dosed another set of volunteers, 2 volunteers who had received norovirus in water for 21 days. None got infected. So we said, okay, somewhere between 7 and 21 days is the point where norovirus still is infectious. So then we tested it at 14 days. And surprisingly, at 14 days, both volunteers still became infected. So then we thought, that's strange. Somewhere between 14 and 21 days, maybe due to sample size, we needed more volunteers to see what happens at 21 days. So we tested 2 more volunteers at 21 days, and one of them became ill. So we thought, okay, it needs to be later than 21 days. We tested at 27 days, 1 volunteer became ill. So at that point, we said, you know what? Our funding was running out. We only have funding for 2 more volunteers. So what do we test? So we decided to test 60 days, in other words, 2 months, to see what would occur. And from that point, there was no point in testing any further, because from a public health perspective, if norovirus was in water, like groundwater, it was just going to cause illness. And so we just stopped the study at that time. So to go back to the evidence for the environmental stability, we showed that in the Emory ambulance, even after disinfection, you could still detect norovirus. And then we also showed that after putting norovirus in water and giving it to human volunteers, they still became infected. So highly environmentally stable and difficult to inactivate. So because of all of this, FDA has responded due to the large number of outbreaks on produce, especially on berries, raspberries, blueberries, strawberries, etc., associated with human norovirus and other enteric viruses like hepatitis A. We have started to see a lot of outbreaks in fresh and frozen berries. And so FDA has responded and implemented a surveillance exercise, and also gave some recommendations early on this year in January. And the Food and Agriculture Organization, the United Nations, as well as the World Health Organization, has set up a series of meetings in order to inform the Codex Alimentarius, which provides guidance for food safety all across the world. And in their second meeting, they identified norovirus and hepatitis A as high-risk viruses and provided a series of recommendations, including that there is a lack of surveillance data, we need to engage in capacity building, and we need to focus on risk assessments to focus on region-specific priorities. So what I'd like to share with you in the next couple of slides is our work to respond to these recommendations from FAO and WHO, and also the needs in the United States with FDA. So the first was a systematic literature review that Nicholas Karame, who was a 12-month global health student, and I conducted as part of his directed study, to look between 2014 and 2024, how many people in the Americas, excluding Canada and the United States, had focused on norovirus and other enteric viruses and quantified them on foods. So as you can see, of all the countries in Central and South America, of all the countries in the Americas, excluding United States and Canada, Argentina, Brazil, Chile, and Mexico were the ones that had published work and had quantified work. But there was a dearth in other countries and other settings as well. And they did not publish that much either in terms of quantifying these viruses on foods. And therefore, there is still a lot of work to be done in the Americas to strengthen capacity building in these countries so that they can include surveillance of norovirus on foods going forward. Then we have been fortunate to receive funding from USDA in 2024 to focus on norovirus on food, specifically berries, and to determine whether we can detect infectivity of norovirus on foods using new detection assays, but also using new risk assessments to be able to predict outbreaks that may result from norovirus on foods. We have been fortunate to receive the help from Milan Barman, who's a PhD student in the Population Biology, Ecology, and Environment Studies program. And we also work with two collaborators, Dr. Callie Neal at the University of Delaware, who's also part of the FAO and WHO Commission, and also Dr. Sanjay Gumala, who is the Vice President of the American Frozen Food Institute, a trade association that focuses on protecting the interests of food industries, especially produce industries, globally as well as in the United States. So we have the industry perspective as part of this. We also benefited from a lot of different partners, current and past students, postdoctoral fellows, colleagues in Mexico as well. And I'll share with you some of their work in the next couple of slides that have contributed to our past grants and also our future grants. So to illustrate some of their work, I wanted to share with you how norovirus can contaminate fruits and vegetables from the farm all the way to the fork, what we call when it's grown all the way to your mouth when you're eating it. So let's start with pre-harvest, when you are growing your fruits and vegetables. And throughout the way, we will use this plush toy of norovirus to illustrate where norovirus can contaminate things. As we have shared earlier, norovirus can contaminate water, such as groundwater. And so I'd like to go back to this work to share with you the persistence in water. And here I'm going to focus on just one of our data. So across the top of our graph, you can see the study that I already showed you, where we have the time in days of the infection from 0 to 63. The filled in dots represent the volunteers that became infected. And then the empty dots represent those volunteers that were dosed but not infected. And then along the y-axis, we also quantify the amount of RNA that we could still detect. So this is the human infection in the dots, but then the RNA levels were what we measured in the y-axis. If the dot is around 0, it means there was no change from when we gave the RNA at day 0 to beyond. So this is a full difference of how much RNA you put in as a denominator and how much RNA you're detecting as a numerator. So if you see everything at 0 or largely above 0, including error bars, it means that there is no change. So you can see we can start seeing a change in RNA detection around 400 days, so about a year later. And it's not until like 2 or 3 years later that we start seeing substantial decreases in RNA signal much, much later, which speaks to how long the RNA lasts in the environment and can still become detected. Other people have also replicated this work with new infectivity tissue culture assays. And so here they tested lake and tap water, and they showed that norovirus was stable, but the in vitro infectivity assay could not detect infection. In their case, when they did an infectivity assay in tissue culture, after 28 days, it was no longer detectable, which is different than our human challenge studies, but the molecular signal was still strong and persisted longer than viable norovirus. So again, there's this disconnect. It's not infectious, but you can still detect RNA, which means that the RNA just lasts for a very long time. And what does this say then about detecting norovirus RNA, which is our current gold standard for seeing if we have norovirus or not in the environment or on produce? So to this point, I wanted to talk a little bit now on norovirus on produce in the environment when it's being harvested. So there's limited data on locations, levels, and modes of contamination. And we did a series of studies that we call the Clean Green Studies in northern Mexico to quantify how much pathogens, including norovirus, there were on our produce items. So here we recruited 10 farms on the US-Mexico border region that produced cantaloupes, tomatoes, or jalapenos because these were at high risk of becoming infected with a series of pathogens. We collected multiple pathogens, including norovirus, but because we suspected that we would not detect many of them, we also detected other bacteria and viruses that were present in large amounts, what we called fecal indicators, and would suggest the presence of feces and likely pathogens, but we would be more likely to detect them. And we focus on the regions of Coahuila and Nuevo León, which border Texas. So what we did uniquely, which was a fusion of food safety together with epidemiology, is we did a match study, a longitudinally matched study, in which we took a produce item and we said when it is born pre-harvest, all the way to when it continues to live and grow as it goes through the processing chain, all the way to the packing facility, what will happen to it? Unfortunately, when we sample our produce, it immediately dies because we have to blend it, we have to mash it, etc. So we can only test it at all these different points, but we can't test the same produce item. So we matched the produce items to those environmental samples that it interacted with, such as water or soil in the ground at harvest, hands when it was being distributed, hands, and when it was in packing facility ready to be sent to grocery stores, also with hands. The other thing that we did that was different than the other previous studies is that we increased the sensitivity of our detection by doing composite samples instead of individual samples. So when I tell you one hand sample, that represents a rinses from 6 hands. When I tell you one tomato sample, that represents a rinses of 54 tomatoes that have been manipulated by these 6 hands as well. So with that, let me share with you some of our data. So in terms of pathogens, from the 636 composite samples in our study, in 2016, when we ended that grant, we found one composite sample of a pre-harvest jalapeno among all our 636 samples that had salmonella. We did not type the salmonella, but we just knew that a pathogenic salmonella was present. Because we ran out of money at the time, we petitioned USDA to give us additional funding to then test for some of our norovirus and hepatitis A. And with our new grant, we identified 3 post-harvest tomato composite samples that had G26 norovirus. So again, very, very low prevalence of norovirus. In parallel to all of this, together with a global health MPH student, Amy Van Pelt, and also Hannah Lofgren. Amy right now is assistant professor at Northwestern, also in global health. We did a systematic review to quantify how much human pathogens are on fresh produce on farms and packing facilities. The gist of what we found is that norovirus RNA has been detected on multiple produce items, such as cherry tomatoes, all the way to watercress, and the prevalence of their detection ranges from 0 all the way to 50%. So all kinds of prevalence. But to date, as of last year, there has not been a lot of studies to look at infectious norovirus. Now, remember, the best way to see if norovirus is infectious is by giving it to a human person, having them swallow it, and seeing what happens to that person. But we then have the next best thing, which is tissue culture infectivity assay, but that's really, really difficult to do. And then the next best thing is to see if the capsid is broken, and we can detect either dye that goes into the capsid, or we can detect RNA from within the capsid once it's broken by addition of RNAs that destroys all the RNA around it and inside of it as well. So the gist of these studies using these proxies for infectivity were that out of 24 store lettuce, green onions, and strawberries, none of them were infectious. And when they looked at cranberries, about 234 lots of cranberries, they found some RNA, but 0 infectious norovirus. So this speaks again that even though you can detect RNA, that says nothing about whether it's actually infectious. And in fact, there was this really unique study out of Singapore in which they replicated the human challenge studies in a very novel way. What they did is they recruited people like you and me and said, for 3 months, please go to the grocery store like the Kroger or to the Publix, buy whatever berry you want. Berries, cranberries, strawberries, put them in your smoothies, eat them fresh, however you want them, just don't cook them. And give us a little bit of the berries that you have consumed and come back so we can ask you questions about symptoms and test your stool. The gist of it is that over these 3 months, they found RNA signal in these berries, but the consumers like you and I that ate these berries exhibited no symptoms at all. So again, this speaks to that we can detect RNA, the genetic material of norovirus on these berries, but that says nothing about symptoms or whether the person will actually become infected. So this is a big deal for the industry because oftentimes we just detect RNA, but as you're starting to notice, RNA lasts for a very long time in the environment. And so does this really mean that there has been contamination and therefore as a cause for concern in our produce? Or do we just have a lot of RNA just floating around there in the environment? So we also did some work on hands, and other of our colleagues also tested people's hands. So here again was in another Mexican state by a series of Mexican collaborators that tested worker hands that had been manipulating bell peppers. And here they found that before work, they found about 31% of hands exhibiting norovirus RNA. And then after 3 hours of work, still hands had norovirus RNA. And this also roughly matched the prevalence of RNA on bell peppers that they found. So this was one study. But you may also recall that our study in another Mexican state, where we tested composite hand rinse sample, we found 0 norovirus, 0 pathogens. And if you may recall, 6 hands correspond to 1 composite. So in general, we found 0 norovirus among 1,000 different hands. So the reality is that probably somewhere between 0 and 50% is how much RNA there likely is on hands, but it really depends on the setting, the detection methodology, and many, many other factors. Now, whether RNA actually means anything for infectivity and sickness and illness, that's yet to be seen, and that is going to be our work. So to this point also, in terms of cause and effect relationships, we also try to investigate using epidemiology and intersect that with food safety. What are the environmental sources of contamination on produce? As you may recall, we had very low prevalence of pathogens, so we really couldn't do anything with pathogens. So instead, we turned to microbial indicators. So at the bottom of this graph, what we did is we tested hand rinses, we tested soil, we tested irrigation water, and we tested source water for the presence of these indicator organisms. So above these indicators at the bottom of this graph, you can see these microbial indicators. For bacteria, we included E. coli, coliforms, Enterococcus. For viruses, we included coliphage. And then what we did on the y-axis is we set up a model in which we matched our hands to our produce and tried to see if there was a relationship between the presence and the amount of these indicators on hands and whether we also would see them on produce. So if you see anything above a 0, that would imply that there is a positive relationship. In other words, we see the indicators on hands and we also see them on produce. If they cross 0, then that means that it could be positive or negative. In other words, it's not significant. We don't see a significant relationship. So what I wanted to point out is that across all the indicators, hands were positively and significantly associated with all the indicators. So if we saw presence of indicators on hands or amounts of indicators on hands, they also corresponded to a log increase on produce. Now, in terms of cause and effect, we're not able to determine what that is, but at least this was one of our first studies that got us closer to determining routes of contamination in the farm and packing shed environment as well. So moving on, we also did similar work on environmental surfaces such as conveyor belts and drain flumes and other things like that. I won't show you the data, but just to share that there is a relationship, also a positive relationship, and some surfaces are more likely to be associated with indicators on produce than other surfaces as well. And so this also helped us and focus our energies in disinfection and sanitization of certain surfaces more than others to ensure that we minimize the chances of contamination of our produce commodities. So the last thing I wanted to then segue to is what happens to our human consumers. Ultimately, all these people are enjoying these delicious fresh fruits and vegetables that have detectable RNA that may have infectious viruses, but how can we protect these? So for this work, I wanted to reemphasize some of the work that the FAO and WHO had emphasized, that context matters a lot. In other words, there are differences across different types of produce and region-specific practices as well that we need to keep in mind. A tomato is different than a berry, then is different than a cantaloupe. We eat different parts of it, and so we need to keep all these things in mind. And then also, blueberries grown in Maine are going to be different than blueberries grown in Washington, and these regional specific practices versus those blueberries grown in Chile, and we need to keep these in mind as well. So there's a need for prevention approaches that are produce and regional specific. So to that point, what we did is we started to shift our energies to develop simulation models. And the first simulation model that we created was what we call in food safety, quantitative microbial risk assessment models, QMRA. And so Julia, a past PhD student, developed a Norovirus simulation model to simulate produce harvest and packing. So just to illustrate what goes into a model is we included all the information I just shared with you in terms of our routes of contamination, our experience, our observations of seeing where produce get contaminated, our quantification of indicators, We focused on tomatoes, and we also quantified how much norovirus we found on these 3 tomatoes that we found in our studies. And we did what we called exposure assessment, which means where are these tomatoes exposed in the environment and what can we do? So I'm going to show you a very complicated and busy slide that I don't need you to focus on the detail, but all to showcase that it is very complicated. On the left-hand side are all the steps that we included in our model for harvest. On the right-hand side are all the steps that we included for the packing facilities. And so we were trying to estimate how does norovirus move throughout the harvest and the packing facility and then go on to contaminate a tomato. And then we put all that into our model with our coefficients from our work and that of others, so that ultimately we could characterize the risk to 1 person. So here, using our QMRA models, we're able to quantify the risk to 1 consumer from consuming tomatoes every single day and what would happen to them. So these were the QMRA models that we use to quantify risk. However, we're not only interested in quantifying risk to 1 person, but we'd also like to quantify risk to populations of people that may participate in an outbreak. And so to this point, we use susceptibility, exposure, infection resistance models, SEIR models, to quantify that population level risk as well. So to recap, QMRA models are great for individual level risks. The benefits is that you can do this very complicated exposure pathway. Is it in the merry-go-round that a tomato gets contaminated? And how much is there a transfer between hands and tomatoes? But the drawback is that there's no time as part of this. It's very limited, and we can't include person-to-person transmission. In contrast, if we use SEIR models, those are great for population-level outcomes. We can include time, we can include person-to-person transmission, but it's hard to get at the detailed level in terms of the individual exposure pathway, and therefore at the specific intervention steps that we need in order to protect our tomatoes from getting infected. So what we did is we said, let's do both. Let's combine both of these models so that we can benefit from the benefits of both of these models. So we took Julia's QMRA model that quantifies individual level risk, and then we combined it with an SEIR model to look at population level risk. And we had used the SEIR model in our previous COVID work under the work of Elizabeth Sajewski, who had been working with Bent Lopman. And so with this new work, we combined the 2 together. And the way that we combined them is we took the very last step, which is the risk to the individual, and we made that the very first step of the susceptibility of the SEIR model that will set off that whole population level based modeling. And the power of that is that then we can look at all the different exposure assessment steps and the quantification of those, but we can also look at the direct effect of consuming a tomato and also the indirect effect of person-to-person transmission. So we assumed for this model that we start with a large town or a small city of 100,000 people. We assume that that everybody loves tomatoes and they eat lots of tomatoes in this large town, small city, and that's equally available to the entire population at their supermarket, etc. And that these tomatoes had the amount of norovirus that we found when we quantified them from our study in Mexico. So first, let me show you our data from individual level risk. So here we quantified the risk for the different age groups that we had. So on the x-axis, you can see our different age groups, and the differences in these different age groups with how much tomatoes they consumed, which we use based on the USDA consumption indices. And then on the y-axis represents the risk per day from consuming tomatoes. So largely, everybody had risk, but young children, because they consume less tomatoes, had less chances of becoming infected. And so then we shifted over to the population-based type part of the model, the SEIR, to see what would happen if everybody consumed a tomato and what would that contribute in terms of an outbreak. So here on the x-axis are the time in days, so from 0 to 40 days. And then on the y-axis is the number of cases that we would see on those days. In red represents the number of people that had symptomatic illness, vomiting, diarrhea, headaches, those kinds of things. And in blue are asymptomatic infected, so those that have no symptoms but still are infected. So with just direct tomato exposure, basically you eat a tomato, you get sick based on these models. We projected that they would contribute to 17 cases if they had this level of norovirus that we detected based on our Mexico study, and that the outbreak would die out pretty fast after 10 days. However, if we also include indirect secondary transmission, which is one person eats a tomato and then makes food for somebody else without washing their hands, then this outbreak lasts longer and the number of cases also increases to 35 cases and lasts for over a period of a month. If you go back to the Emory norovirus outbreak, our outbreak was also about a month, in which then it died out. And we would probably see the same thing here as well. So we have this power now that we have now simulation models that combine the best of both worlds and can be used for outbreak prediction and scenario building as well. So in terms of some of the key takeaways from the research, to address produce safety challenges from norovirus, we need systems level thinking to look at all the different stages of contamination, but also these interdisciplinary approaches, not only food safety, but laboratory, epidemiology, and simulation. And to respond to FAO and WHO, simulations are a powerful tool so that we can then start to make recommendations for specific types of produce and specific regions that may not have data available in order to prioritize some of these effective interventions. So just wanted to acknowledge some of our funding sources and some of our collaborators as well. And now I wanted to just take a few minutes just to talk about the wrap up to living your best life while managing a public health emergency. And then I'll open it up for question. What is your aftermath to all of these things? So to wrap up and to remind you, my mindsets during the 2014 Emory outbreak were two draining mindsets. One, other people's needs are more important than my needs. And two, I can get everything done if I just organize and plan well. So I'm going to stop sharing and I'll tell you what I have learned from this experience in a more intimate one-on-one setting. And I also encourage you to think about what you have learned from crises and emergencies and share them with us in the chat or also in the Q&A or else one-on-one with your colleagues and mentors after this conversation. So if I could go back in time, what would I do differently? And I would definitely, my mindsets have changed since then. So one, I have realized that I am the most important person out there and I need to focus on me first in order to be able to be successful at managing crises, emergencies, and other items as well. And I need to set up systems of success to help me be successful and help me to respond to these crises. And number two, at every moment in a crisis, I can't do everything at the same time. I have access to an infinite set of possibilities, but I have to pick one, and then I have to finish it before then picking the next one among these other infinite possibilities that can take place. So all these mindsets sound fine and very ethereal, but how can I translate them to practice? And what would I have done differently in the norovirus outbreak? So the first thing that I would have done differently is I would take advantage of a superpower that you and I have because we're researchers. We're amazing at asking important and also really interesting questions. So I would use that superpower to myself to help me with these two mindsets. And either in the drive home or after making dinner for my husband that night, or maybe in the morning after, I would set a timer for 15 minutes, play my favorite music that helps me think, and I would answer two questions. Two questions that would be my compass to guide me through this crisis and this emergency. The first question would be, where do I want to be after this crisis, this emergency has passed? And number two, what is important for me to take care of for myself on a day-to-day basis of this crisis, of this emergency, so that I can be successful? And again, these two questions, the answers to these questions would help me navigate the crisis on a day-to-day basis, but also make decisions in prioritizing what I need to do after the crisis and the emergency is finished. And if I had to prioritize one system of success, I would prioritize my body overall. My body, because in order to be able to use my brain to collect information from the outbreak that was happening, synthesizing it, and then making recommendations to Emory leadership, my brain needs to be well-nourished and active. In order for me to access and tap into my emotions and engage with different students, staff, and faculty, and commiserate with their illness, ask them to give me stool, which is very, very hard to do. It's very hard to ask somebody to give you their stool specimen. So be able to engage with them empathically with my emotions to get them to give me some of their precious stool sample, but also to respond to Emory leadership when they're angry in meetings and saying, why didn't you have information yesterday so we can deal with it today? And lastly, my intuition. We have this ability to identify patterns and fill in missing data so then we can provide information when data is not there. If I'm tired, anxious, hungry, and my body is not taken care of, I'm not able to answer my mind, my emotions, my intuition to be successful. So the last thing I wanted to say before I open it up for Q&A and other ideas that you all may have is my small grain of sand contribution in terms of what I'm trying to do right now for our colleagues here at Emory in terms of faculty and staff, and also for the public health workforce. All of us are doing different actions and activities for ourselves, our teams, and our larger colleagues. So this is the grain of sand that I am doing right now, thanks to the help of many of you here on this webinar as well. So I invite you to participate in our conversation at the end of May or again in fall, a small weekend course here at Rollins on the Emory campus called Your Best Public Health Life, Wellbeing and Impact, where together we identify different elements of purpose and well-being so that you can respond to your work and have the impact that you desire. So again, thank you to everybody that has supported this journey in developing this course and everything else that we are currently doing. I'll drop this in the chat box as well if people are interested in learning more. And at this point, I open it up for any questions or comments or feedback that people may have on anything that has been covered. So thank you for your attention.
Hello, hey, Juan, thanks for this excellent presentation, which include many of your previous Norovirus studies. So I will start with a high-level question. So as you know, we and other Norovirus people have been working on Norovirus research for over like half a century, but Norovirus is still a problem. You know, there's no vaccine available against Norovirus. There's no like effective like antiviral drugs against Norovirus. So outbreak is still like happened in the world, like in China, other countries last year and this year. So my question is, what Norovirus people should focus on in the future? Like, should we continue develop Norovirus vaccine, or should we develop like antiviral drugs against Norovirus?
Thank you, Pengbo, for this excellent question. I think we need all fields participating as part of this initiative. So you're absolutely right that we need the immunologists thinking about a norovirus vaccine that can support this work. At the same time, we need the public health communicators that can inform and train the public on how to prevent norovirus contamination, and also at the level of growers, at the level of restaurant managers. We need policymakers to also implement different aspects of the food code. So we need everybody to pitch in and support this initiative so that together we can respond from a multidisciplinary lens like is public health to do this. So thank you, Pengbo, for this excellent question. Okay. If there are no further questions, thank you very much for your participation in this conversation. I'm going to stick around until 1 o'clock if people want to do one-on-ones or drop something in the chat. But if not, please enjoy the rest of your Wednesday. Enjoy delicious fruits and vegetables, and all the best as we are all contributing to the public health community during these times. Thank you, everybody.